Good morning, everybody. Thank you for joining us for the Senate Committee on Education and Health Subcommittee on Health Professions. The first bill that we have this morning, again, we will not have remote testimony because this is a subcommittee. And if your bill has passed with a cognate in the Senate, there is no need for you to present your bill. We're going to start with I see Delegate Glass right here. HB 324, the PA Licensure Compact. It passed 99 to 0 in the House. You want to come on up? Mm-hmm.
Thank you, Madam Chair. How this bill is, it's exactly what you said, a physician assistant compact. It's a licensure that would allow for interstate license for physician assistants. It provides what it would be as a streamlined process via a compact for privileges to be practiced as a physician assistant in multiple states. Currently, there are 3 states in the compact. It takes 7 to enact one. If we pass this, it would put us on the path to be at the table to determining the standards and practices for what that compact could be. And that is the bill.
Great, thank you. Any questions of the members? Do I hear a motion? All righty, we have a motion, a second to recommend reporting. Please call the roll.
Senator Pekarsky. Senator Head. Senator Bagby. Senator Pillion. Senator Boysko.
Aye.
Ayes 5, nay 0.
Ayes 5,
Gratitude,
nays. We
Madam Chair.
recommend your bill reports. Thank you. Thank you. Delegate Cole.
Good morning, Madam Chair, members of the committee. Good morning. I have before you
HB 426.
426, and I have a substitute on the bill.
Okay, can you tell us, do we have a motion to move the substitute?
It's a move. Second.
All righty, motion and a second. All in favor of accepting the substitute, please signify by saying aye. Aye. Any noes? Okay, tell us about your substitute.
So the substitute simply changes the bill over to, instead of having no licensure, it now moves it to asking the Board of Counseling to accept the NCE exam. And this exam, from my understanding, many students before they graduate with their master's are required to take this exam. It's also accepted by the Counseling Compact. So I believe with this substitution, we now have peace in the valley among some of the contentious thoughts that we had going around.
Excellent, thank you so much. Any questions from the members? Okay, do I hear a motion?
Second.
All righty, motion and a second. If we could call the roll.
Senator Pekarsky.
Aye.
Senator Head. Senator Bagby. Senator Pillion. Senator Boysko.
Aye.
Ayes 5, nay 0.
All righty, 5-0. Thank you for your time. Absolutely. Delegate Tran. Good morning.
I have 2 bills with you.
Okay.
Good morning, I have 2 bills with you.
All righty, which would you like to start with?
Can we start with House Bill 971? Maybe I should start by saying that we have peace in the valley on this bill, which is our bill to reduce the time that nurse practitioners have to practice under supervision before they can practice autonomously. The current is 5 years, and the bill and the agreement we have amongst partners is to 3 years. We also make another significant change that's also important regarding the existing patient care team that is supervised by the physician. Would you like me to go through those changes, Madam Chair?
Sure, if you would like to, just to make sure that everybody hears.
Okay. So currently, if a physician is no longer able to supervise, the nurse practitioners under that team have 120 days to find a new supervising physician. And what the bill allows is, after the 120 days, if another physician is still doesn't come forward, the board may appoint a autonomously practicing nurse practitioner who's practiced with that group of patients before to step in as a supervisor. And I think the other important thing I'd like to note is both the Medical Society and the nurse practitioners will continue to have conversations and dialogue post-session so that things that they can work things out or bubble things up beforehand.
Thank you so much. I think there are some questions from the
Madam Chair,
Senator Pillion.
Tran, we hear this bill almost every year. And I understand there is peace in the valley, but are we going to hear this bill again next year? And you're going to come back for 2 years?
Delegate Tran?
Yes, Madam Chair, I would like to phone my friend who are here. We have the nurse practitioners here with us today, and I think they can speak more to that.
Hello, Richard Grossman representing Virginia Johnson Nurse Practitioners. And we had always said that Virginia was an outlier at 5 years and we wanted to be in the mainstream, which is 2 to 3 years. So this puts us firmly in that mainstream and we were satisfied.
So, Madam Chair,
Senator Pillion.
follow-up question. So is that a commitment that it will be 3 more years or 5 more years before we hear back from them, wanting it to lower to 2 years or 1 year or no years?
Delegate Tran?
Madam Chair, I would allow our nurse practitioner friends to answer that question
Thank you very
directly.
much. Mr. Grossman?
We have an agreement not to come back in the foreseeable future, and especially next year, and to begin dialogue with the medical society on this issue and plethora of other issues.
Thank you. All righty.
Madam Chair, if I could just sort of weigh in on that.
Senator Head?
Yes, Madam Chair, just to say, I'm 61 years old. If I live to be 100, I don't ever want to hear this again. Thank you.
Delegate Tran, thank you so much. So, are there,
I am 47 years old, and I expect to hear this again.
all righty,
Move the
so,
report.
and a second?
Second.
All righty, we have a motion and a second. If
So
the,
I guess there's no one else even.
I believe we have Peace in the Valley, if, yes, the doctors are, the physicians,
I think you have one group of doctors that are not.
We have some piece.
hey, introduce yourself.
On behalf of Virginia College of Emergency Physicians, we have spoken to the delegate. She's aware. We are not supportive of this. We think the number should stay at 9,000 hours. Everybody knows that as well, but I wanted to say that. We're especially concerned in the emergency department, and we feel like that number, if you're going to practice independently, should remain at 9,000 hours. So thank you.
Thank you very much, I appreciate that. We have a motion and a second. The clerk would call the roll.
Senator Pekarsky? Senator Head? Senator Bagby? Senator Pillion? Senator Boysko?
Aye.
Ayes 5, nays 0.
The bill passes, or is recommended for reporting, 5-0.
Madam Chair.
Thank you so much. In a similar vein, since we're talking about advanced practice nurses, and I know that Delegate Sickles is not in the room, but I just wanted to move that his bill be continued for the year with a letter to the,
She's got no.
No, you
oh,
should.
you still have another, we're just going to take care of this since we have all the folks who are concerned with that. Move that,
Motion.
thank you.
Second.
Continued with a letter from the chair to the Joint Commission on Health Care. We have a motion and a second to continue to 2025. If you could call the roll.
Senator Pekarsky? Senator Bagby? Senator Head? Senator Bagby? Senator Pillion? Senator Boysko?
Aye.
Ayes 5, nays 0.
All right, it is recommended, continuing 5-0. Delegate Tran, your second bill is
Thank you so much, Madam Chair.
995, HB
Yes.
995.
Members of the committee, so House Bill 995 helps to address a couple of different issues. One is the physician shortage that we are experiencing in Virginia, and the second is ensuring that immigrants and refugees who are international medical graduates, where they have their medical degree and have experience practicing, have a pathway to licensure. As you may know, 102 out of 133 counties and cities in Virginia are federally designated primary care health professional shortage areas, which is covers about 29% of our population. Many of these are rural and urban communities, and many of them are also New American and communities of color. And so what this bill does is it creates a 2-year provisional license that could be issued by the Board of Medicine to qualified internationally trained medical graduates. So they have, in order to be eligible for the provisional license, they have to have trained in a legally chartered medical school outside of the United States that's been recognized by the World Health Organization, and have that degree and like affirmed by a third party. So go through kind of a pretty intensive process for doctors to get that affirmation. And they have to have practiced medicine for at least 5 years. They then have to take steps 1 and 2 of the United States medical licensing examination and pass both of those exams, and enter into an agreement with a medical facility, so a hospital that is willing to assess their skills. So this is kind of like where you have to be currently to enter a residency program, if you're an international medical graduate. But because residency slots are so few, this provides them with another option. After you have practiced with that hospital or clinic for 2 years under full-time employment, and did that well, then you are eligible for a 2-year restricted license if you pass step 3 of the license examination, and have a commitment to work in one of those underserved areas in Virginia that has been identified by our Department of Health. After you practice in that underserved area for 2 years and do that well, then you are eligible for full licensure and can practice anywhere. When we were heading earlier this session, we had refugees who came and visited us from the Harrisburg area. I met 4 doctors from Cuba, 2 of them who are now working in poultry plants in that community. So I think this helps us allow folks who have the skills and knowledge to fully provide for their families and to help meet some of the healthcare shortage issues that we're experiencing.
Thank you very much. Do you have anybody here to support your vote?
I do.
Alrighty, if they'd come forward, please introduce themselves.
Morning, Madam Chairman, members of the committee, Scott Johnson, on behalf of the Medical Society. We worked with Delegate Tran when the weather was about 90 degrees throughout the summer, and she was kind enough to accommodate all of the safeguards and guardrails, so we support this.
Excellent, thank you so much. Yes,
Chair Brent Rawlings from Virginia Hospital Healthcare Association, we also support.
thank you so much.
Madam Chair, I'm Brandon Kilmer. I'm co-founder of the Refugee Physicians Advocacy Coalition. We bring together 25 resettlement agencies, nonprofits, and national subject matter organizations in support of HB 995. Through the RPA, I've interviewed 51 refugee physicians in Virginia and the DMV, and they're from different continents across the globe, but their experiences are sadly the same. They want to work in medicine, but they end up in low-wage jobs like driving Uber. Some are lucky to have medically adjacent pharmacy techs or patient-level assistants, but returning to medicine is unattainable for them because of financial or residency slots are too scarce. And we passed the HB 995 so the RPA can do our part to help qualified doctors use this pathway to return to practice in the hospitals and health clinics where they're most needed.
Thank you so much for your testimony. I think this bill is in good shape. If
Yes, Senators, I'm Dr. Aziz Jani. When Afghanistan government collapsed in 2021, my wife and I left the country with my young children. My wife is specializing in obstetrics and gynecology, and I'm a general surgeon and medical professor with over 20 years of clinical experiences. I'm also one of the founding members of Afghan Civil Society. It has been so disheartening to be unable to use our experience and expertise, especially knowing that our services are needed in Virginia and could even help other recent Afghan and refugee arrivals. But I'm not ready to give up, and I'm eager to get after again. That's why I strongly support HB 995. I dream of the day when this bill becomes law and this opportunity becomes a reality for doctors like my wife and me and so many others. Thank you very much.
Thank you so much for your testimony. One more doctor. Yes, sir.
Good morning, Madam Chair, ladies and gentlemen. I appreciate graduate from Afghanistan. I'm a pediatric surgeon with 10 years experience in that field. And besides this, I have served as head of Afghanistan Council for all licenses for all Afghan doctors. And besides this, I was working with USAID, WHO, and other international organizations how to implement a good health system in Afghanistan. After arriving to the United States in 2021, I was lucky to select as a fellow
Thank you all so much for taking the time to come to Richmond to tell us your stories. Are there questions from any of our colleagues? Okay,
Recommend reporting.
Second.
all righty, we have a motion to recommend. If the clerk would call the roll.
Senator Pekarsky. Senator Head. Senator Bagby. Senator Pillion. Senator Boysko.
Aye.
Ayes 5, no 0.
Thank you so much.
Thank you so much,
Your bill is recommended 5-0.
Thank you.
All righty, Delegate Candy Munyon King, please join us at the table. All righty,
Good morning.
Delegate Munyon King,
Good morning.
good morning again. Tell us about HJR 87.
Okay. HJR 87 is a bill to honor, I have the wrong bill up. It is a resolution to honor the contributions of domestic workers.
This, actually, I think this should be at rules. I don't know
I
why.
thought so too.
No, 257.
257.
Why is it on mine? Oh. Okay,
You got
thank
a lot
you.
going on this morning.
I got a lot going on this morning.
I got you, baby.
I
I
have,
was going with you though.
I have,
You
I
want to go
have.
ahead and present that bill in this
Thank you.
committee?
All righty. I was like, this doesn't seem right. It's like SJ.
You want to talk about that bill? We'll talk about
All righty. How about we hear about HB 257?
Yes. So, House Bill 257 is a bill aimed to help those with sickle cell anemia. A few years ago, all across the country, we started prescription monitoring programs to help people avoid opioid addiction and to help with prescribers and doctors. And for years, what has happened, and we have research from the National Institutes of Health and other organizations, is that the prescription monitoring programs have had unintended consequences for people with sickle cell anemia who rely heavily on opioid medication to manage their really painful disease. And so what this bill does is it exempts them from certain requirements of the prescription monitoring program, which will help prescribers easier not have to go through as many steps to prescribe them. And I give the example because, of course, this is personal for me. I have a child with sickle cell anemia who has some of the best care in the Commonwealth in Northern Virginia, care that we would love to see across the Commonwealth. But when she received her first prescription at the age of 11, she was very blessed to make it that far without needing opioid medicine. We had a lot of hoops to jump through to get her more than a 7-day prescription. And when she was in a crisis for 3 weeks and she was fine for a week, and then she was in another crisis for 2 weeks, it was like, you know, what's going on? And it just puts families, especially those outside of urban and areas with a lot of hematology and other support, it puts them in a difficult position. So what we want to do is we want to exempt certain people with sickle cell anemia. This will still be reported. Everyone will still be able to see, but the prescribers won't be required to use this information before they make those prescriptions.
Thank you very much. Did you bring anyone with you to?
Not that I know of.
Okay. Are there questions from my colleagues on the subcommittee? All righty. We operate by motion.
So that was my original bill, if I'm not mistaken. And I'm sorry for the unintended, Madam Chair, I'm sorry for the unintended consequences. And we had thought that we'd carved long-term pain and some areas that were necessary to carve out, but my apologies that happened.
Thank you.
And I will say, Madam Chair, to the Senator, that you all did do a great job, and there are, you know, bone cancer carve-outs and other people who require long-term opioids, and this would just be adding sickle cell to that group.
Thank you for bringing this forward.
Absolutely.
Do we have a motion?
Recommend reporting.
All righty. Okay, we have a motion and a second. If the clerk would call the roll.
Senator Pekarsky. Senator Head. Senator Bagby. Senator Pillion. Senator Boysko.
Aye.
Ayes 5, nay 0.
Your bill is recommended reporting 5-0.
Thank you,
See you.
and I will
Thank
see you
you.
in about 30 minutes.
Thank you. Appreciate it. I know that a lot of people have committees to get to. I'm trying to move us through this. If Delegate Maldonado would like to join us. HB 1389.
Yes, Madam Chair.
All righty, tell us about your bill.
I'm hoping that this, Madam Chair, is a quick bill for you all. It is a technical bill that just cleans up some language in our code. Athletic trainers actually practice in inpatient settings as well as outpatient settings, but the lack of clarity in the code has created some confusion about what's permissible. So athletic trainers you see them most often in, say, sports games, but they're also in rehabilitative conditions and environments in hospitals, in physical therapy offices. So this is meant to make that clear. There is an amendment to line 95. I'm not sure if you have it, just simply adding the word including in front of the in and inpatient and outpatient setting.
Second. Alrighty, we have a motion and a second. All in favor indicate aye. Any opposed? Okay, so we have the amendment in front of us. Did you bring anybody with you who wished to
Not
speak on
today.
it? Alrighty, is there anybody in opposition? Hearing none.
Second.
Alrighty, we have a motion and a second. All, please call the roll.
Senator Pekarsky. Senator Head. Senator Bagby. Senator Pillion. Senator Boysko.
Aye.
Ayes 5, nays 0.
Your bill is recommended for reporting 5-0. Thank you so much.
Thank you, Madam Chair, members of the committee.
Delegate Willett, your bill is substantially similar to Senator Head's bill, I believe.
That is correct.
So, is,
Hopefully identical at this point, but.
okay, is it, can we just get confirmation?
I believe that Willett has the same substitute that I presented to the
Okay.
House Committee yesterday.
Yes.
Okay,
So that will make them absolutely identical.
okay, so since this committee has already discussed and considered it, we will not go into,
Or amendment.
do we need, do we need, move the substitute? Alrighty, all in favor, aye.
Recommend reporting.
Alrighty, second?
Second.
Alrighty, there's a motion and a second. If the clerk would call the roll.
Close your folder.
Senator Pekarsky. Senator Head. Senator Bagby. Senator Pillion. Senator Boysko.
Aye.
Ayes 5, nays 0.
Alrighty, you're on the way, 5-0 to the full committee. You shouldn't need to show up for that either.
That's awesome. Thank you.
Okay, great, thank you so much.
I did have one.
You have another one?
Oh, yeah.
I did have one other one, yes.
Okay.
Yeah.
Thank you. I'm just trying to race people through here.
It's okay.
Alrighty, why don't you tell us about that one as well?
No, thank you, Madam Chair, members of the committee. So I don't think it's lost on this committee that we're losing up to 7 Virginians per day from overdose deaths in Virginia. Statistics also show that there are an even higher number of, record number of overdoses that don't result in death, so non-fatal overdoses. Right now, there's a distinction in access to information on non-fatal overdoses, so it would be great to be able to get that information, but right now the providers, we do a great job of tracking information of folks who have died from overdoses, but for those who haven't died, the non-fatal, doctors cannot get that information through the prescription drug monitoring program. This bill would enable that, expand the program so they could see that, and I think that's going to be a great help to them in making a better diagnosis of these patients and just try to stay in front of this terrible overdose issue. So that's what it does, and there's a funding mechanism to support that, some programming that needs to be done at VDH as well as the Virginia Health Initiative, and we've had a great cooperation there, and I think we can get everybody on the same page and make that system better.
Does this go to finance or no?
I do not have a, okay, we don't have the letter.
Move to
Alrighty.
report if you're ready, Madam Chair.
Is there anyone in opposition to this bill? Let's just make sure. Alrighty, hearing none. We have a,
Let me ask you a question. Yes, Madam Chair. Delegate, do you see any unintended consequences of this? Do you feel like people would be less inclined to show up to the ER, or they recognize that there was a supportive mechanism that? Madam Chair, I appreciate that question. I think, honestly, I think people think it's already being shared because, your doctors are supposed to be, they do access this database already to check on drugs. They're just not getting that information on the non-fatal overdoses. So I think a lot of folks think it's already done. It's not. Right, Madam
Okay.
Chair, it's a great bill. I just, good question.
okay. We have a motion and a second. If the clerk would open the rolls.
Senator Pekarsky. Senator Head. Senator Bagby. Senator Pillion. Senator Boysko.
Aye.
Ayes 5, nays 0.
All right, your,
so much.
your bill is recommended for reporting 5-0. Delegate Hodges, you look like you are ready to go.
Yes, indeed. Thank you,
And
Madam
then
Chair.
Laura Jane.
Good morning.
Hi.
I have before you, this is low, House Bill 1068. So this legislation really empowers the Board of Pharmacy to promulgate regulations aimed at enhancing the safety and efficiency of prescription drug dispensing. And really at its core, it authorizes pharmacies, whether they're in the state or out of state, to outsource certain dispensing tasks to central fill pharmacies. They will ensure that central fill pharmacies operate with safety and efficiency. There will be sufficient automation to provide the support. It's limited to Schedule 6 medications. Also clear guidelines for pharmacist oversight, and the pharmacists will be empowered to determine the maximum number of personnel they can safely supervise, ensuring that patient care remains paramount. Moreover, the legislation permits personnel to assist in non-dispensing functions, provided they are supported by appropriate technology, barcode scanning, and as I've said before, it prioritizes patient safety, streamlines pharmacy operations, will help pharmacies. You've all seen the issues at the retail level with the long lines and the issues that we're dealing with, and it is brutal. This will help streamline that process. And whether it's chains or independents can actually contract with these services, chains can do it, and so forth. So it will help streamline that process and help patients in the long run. And there is a substitute. I'm sorry that
Right.
the board actually had recommended a couple of technical changes.
All righty, we have a substitute. Do
Sorry,
we have a
Madam
second
Chair.
on that?
Second.
All righty, we have a motion, a second. All in favor? Aye. All righty, so we have the substitute in front of us. This bill passed with unanimous vote. Is there anyone here in support or opposition of the bill?
Recommend reporting.
All righty.
Second.
All righty, we have a motion, a second. If the clerk would call the roll.
Senator Pekarsky. Senator Head. Senator Bagby. Senator Pillion. Senator Boysko.
Aye.
Ayes 5, nays 0.
All righty, your bill recommends reporting 5-0.
Thank you, Madam
Thank you for
Chair.
your time.
Y'all have a great day.
Delegate Cohen. Thank you for your patience.
Of course, no, thank you.
You've got two bills in front of us today, correct?
Yes, Madam Chair, I do.
Alrighty. Which do you want to start with?
I guess I'll start just in order, 503, if you don't mind.
Alrighty.
503 is a bill that is, well, a Section 1 bill that would direct DMAS to amend its regulations for the definition of credentialed addiction treatment professionals to include licensed behavior analysts. It's a simple bill. The goal is just increasing the number of providers treating substance use disorder. For me, I took this bill on. I lost my sister to addiction, substance use disorder. And currently, licensed behavior analysts are trained to provide these services. It is within their scope of practice, but they can't be reimbursed by Medicaid for their services because in the DMAS regulation, it states credentialed addiction treatment professionals treat substance use disorder, and LBAs are not currently included in this definition. And it's likely because they were only licensed in this area in 2012. So companies would like to hire LBAs to deliver treatment, but because they're not considered CATPs by DMAS, they are unable to be reimbursed.
Thank you. I'm sorry for your loss. I was not aware of that. That's really horrible. Are there questions from the members? Did you bring anybody with you who is supporting the bill?
Not to the best of my
Alrighty.
knowledge.
Is there anybody in opposition? Okay, this went through the House 100-0.
Second.
We have a motion and a second. If the clerk would call the roll.
Senator Pekarsky. Senator Head. Senator Bagby. Senator Pillion. Senator Boysko.
Aye.
Ayes 5, nays 0.
Alrighty, your bill is recommended for reporting 5-0.
Thank you very much.
And you have another one, 511,
Yes.
HB 511, if you tell us about that.
Yes, it addresses a code section. 2 sessions ago, we passed a bill that allowed certain practitioners, like healthcare practitioners who were licensed, certified, or registered in another state or DC to temporarily practice for a 90-day period while they were getting their Virginia license, provided that they were contracted by or received an offer of employment in the Commonwealth from a healthcare employer. Those employers, though, were listed as hospitals, nursing homes, dialysis facilities, the Department of Health, or local health departments, but not assisted living facilities. So this was a bill that I think it was just an oversight. And so certainly our assisted living facilities who struggle, like so many different groups to find licensed healthcare providers, would really appreciate being able to participate in this as well.
Okay. I feel like we had a similar bill and we didn't have a set. No? Maybe I was just already reading this. Okay. Did you bring anybody with you in support of this?
Madam Chairman, Scott Johnson on behalf of the Virginia Healthcare Association and Virginia Center for Assisted Living, and we support the bill.
Okay, thank you so much. Is there anybody in opposition?
Recommend report? Yeah, recommend report.
Okay, we got a motion, a second to recommend reporting. Clerk, call the roll.
Senator Pekarsky.
Aye.
Senator Head. Senator Bagby.
Aye.
Senator Pillion. Senator Boysko.
Aye.
That's 5, nay 0.
Alrighty, it recommends reporting 5-0.
appreciate it.
Delegate Zer. Do you need?
Good morning.
Alrighty, good
Committee,
morning.
Madam Chair. On behalf of myself and my co-patron delegate Rasul, we bring you the 5-needle protocol. This is it's been a proven asset in the treatment of anxiety and depression. It's a low-cost, non-drug alternative, and we just ask for making this more widely available. And I do have someone here to speak, and if there are any questions about it.
Okay, thank you so much. If whoever is here to support the bill would come and speak to us, please. Introduce yourself.
My name is Katie Clifton. I'm an acupuncturist in Roanoke. During COVID, I realized that who I was treating in my private practice, healthcare workers, teachers, family members of people who suffered from substance use disorder, was increasing. So I started a nonprofit called the Wellness Wagon. We perform the 5-needle protocol off the Wellness Wagon. I'm an acupuncturist. I have to go to school for 3 to 5 years postgraduate. And so this allows people who have been trained in just the 5-needle protocol to perform this. And so off the Wellness Wagon, we treat not only people with substance use disorder, we also treat their whole support system. And this bill, right now, you can only use this in chemical dependency settings, but this bill would expand that so that we can treat what we do off the Wellness Wagon, is treat the whole support system, their family members, their healthcare workers, their community care workers. We work with the Rescue Mission in Roanoke City. We've treated the ER doctors at Carilion. It's a very beneficial treatment.
Excellent. Thank you so much. Questions?
Just
Senator,
real quickly, because I'm in looking at the bill,
Senator Head.
we're adding in the section of practice of acupuncture does not include the 5-needle protocols. What you're adding into that, but what you've currently got in code is that it doesn't include the procedure of auricular acupuncture as exempted in another code section. Is the 5-needle I mean, are we restricting something, or
We're expanding it. So as an acupuncturist, I can practice this, but I can't treat all the people that need to be treated. So right now, currently under the current bill, people go through a 70-hour training and they learn these 5 points that they can do in the year. So it's not acupuncture. It uses acupuncture needles, but it's just these 5 points. And acupuncture is a much larger medicine than that. So this is just 5 points in the ear. Might give somebody a bruise, but that's rare.
Thank you.
Does that make sense?
Are there other questions from Senator Head?
I just want to make sure that by restricting it to that we're not I mean, there's not anything that is open, because now it's limited to by doing this with this language, it's only the 5-point protocol. Is there something else that's expanded out of that?
And ma'am, speak to the chair, please.
Sorry, Madam Chair, excuse me. That it is we only want the 5 needles in the ear. We want it very limited so that the training covers everything. So we do not want to expand it to any other points at this time.
My understanding is that it's not touching the acupuncturist scope of practice, but it's adding something new for a specific treatment. Is that accurate? Okay. So is there anyone here in opposition to the bill? Okay. Any other questions or discussion? There, Senator Head, I believe there are other auricular treatments in acupuncture, but this is, those are,
Those are excluded, and when we pass this, those will no longer be excluded, only the 5 point will be excluded.
Yes, but they're currently under Virginia law. They're actually not excluded. I mean, in the military, they use battlefield acupuncture, which I'm not even sure that is covered under the current law.
Mr. Senator.
The only thing I'm concerned is I just want to make sure that we're not taking something that is currently not restricted and making it restricted because we're narrowing it down on this. I'm fine with the bill. I don't necessarily.
Senator Head. Thank you. Senator Pillion.
Madam Chair, I think.
If staff might be able to clarify for us, just to make certain that we are.
Madam Chair, I think the question to staff is this bill, the way we're if we pass this bill, does it make it more restrictive
For the other.
than expansive? If we narrow it down to just this 5-point auricular technique?
Madam Chair, I would say that as it appears in this code section and as the individual who is speaking attested to, the intention does seem to be to expressly make this expressly applicable to that 5-needle auricular acupuncture protocol. Now, as you noted, as Senator Pillion and Senator Head noted, previously it did not specify the 5-needle, leaving it open to auricular acupuncture in general. And so I would say that as applicable to these two code sections, it would be limiting it to only that 5-needle auricular acupuncture, unless there's elsewhere in the code that I'm not aware of that provides something more general.
Madam Chair, the intent of the bill is not to limit, but to expand. Am
That,
I correct?
Mr. Senator Pillion, that is my read on the bill. And
Madam Chair, excuse me.
yes, ma'am.
I believe that the original bill calls it acu-detox, and we want to move away from that. It's the same treatment. It is the exact same treatment, but we want to move away from the detox language because after 9/11, it was found to be so effective to treat first responders. So, but a first responder is not going to go to an I mean, they might, but in our experience, they don't want to go to an acu-detox clinic, but they would go to a 5-needle protocol. So the language has also been changed. But in the original bill, it's the same protocol, different name.
Thank you for the clarification. Okay. Are there other questions from the members? Do we have a?
Recommend reporting.
All righty, is there a second? Okay, if the clerk would open the roll. Thank you.
Senator Prakarsky? Senator Head? Senator Bagby? Senator Pillion? Senator Boysko?
Yes, aye.
Ayes 5, no 0.
The bill is recommended for reporting 5-0.
Thank you, Madam Chair.
Thank you. Delegate Davis, I believe you have a bill. Thank you so much. Please tell us about your bill.
Madam Chair, HB 848 will help address the shortage of veterinarians in the Commonwealth of Virginia. The bill will simply allow graduates of DVM schools to practice under the direct supervision of a licensed veterinarian, and I ask that this bill be reported.
Thank you very much. And this has an emergency regulation to implement it. We are under a shortage of veterinarians at this point. Do you have anybody with you who is supporting the bill? You do? Yes, if you'd come up and tell us. Thank you so much. All righty, anybody in opposition?
Recommend reporting.
All righty, we have a motion and a second. If the clerk would open the roll.
Senator Pekarsky? Senator Head? Senator Bagby? Senator Pillion? Senator Boysko?
Aye.
Ayes 5, no 0.
All righty, Delegate Davis, your bill is recommended for reporting at 0.
I'm supposed to do this one, but we can do Hope.
Okay, if Delegate Hope would join us, please.
Thank you, Madam Chair. I'll start with, Senate Bill 34, that's a low chair.
342.
This is kind of like
It is a lot.
old school,
You
having
can
it at
bring
the
it-
table.
You can rise, make your chair rise
Yeah,
up.
no, I want to be, I could use that one. I'm okay right now. So-
All righty.
so why don't we do
You have
342?
342 first.
Which I think will be easier. What we're doing here, obviously, everyone recognizes naloxone, the importance of it for bringing someone back. It just requires each state agency to possess naloxone in all the state agencies. I think we see them everywhere in our schools and elsewhere. And the other thing that it does is it requires the Virginia Department of Health to put on their website, talk about the benefits of opioid reversal on their website. That's all the bill does. It's very
Okay.
important.
Second. Oh, I can't second it. Okay. All righty. We have a motion, a second. If the clerk would call the roll.
Senator Pekarsky? Senator Head? Senator Bagby? Senator Pillion? Senator Boysko?
Aye.
Ayes 5, no 0.
Your bill is recommended 5-0 to the full committee. And you have a second bill.
Thank you, Madam Chair, and I do think this will require some more discussion, and I hope, this bill was presented, House Bill 516, was presented in our subcommittee, and we have 2 pharmacists on our subcommittee. And I don't know if you've ever struggled with pharmacists, Senator Pillion, or not, but they're trouble, I tell you. But this bill, it came to me from one of my constituents, and talked about what's happening in other states. This would just require pharmacies to notify a person receiving a prescription drug that an accessible prescription label, we also call a prescription reader, is available upon request at no cost for the individuals who are blind, visually impaired, or otherwise print disabled. This has generated a lot of attention, and we have a big problem in Virginia to solve this. We had heard testimony from people that are visually impaired. Imagine taking multiple medications and the bottles look very similar. And if you can see, that's not an issue because you know which one. You can read the label. You know what's maybe has a red top or something like that. But if you're visually impaired, it's not so easy. And I admit that I don't spend as much time when we post testimony at our subcommittee hearings in the House that people can not only just appear for the meeting, but they can submit written comments. We received nearly 50 comments from people across Virginia about how big of a problem this is. And so this has demonstrated to me that this is an issue that we need to address. I will, in full disclosure, I know the pharmacists are concerned about it because there is some cost involved. I know that there's actually difference of opinion of how much costs are involved. But this is a pro-consumer bill. We have an issue that we need to solve. People end up in the emergency room or even worse when they take the wrong medications. And so it's really important that we figure out a way to solve this problem. I know that we have people here to speak in favor of the bill. And so I'd like to the subcommittee hear their testimony. It's quite compelling.
I would be happy to have them come speak. Yes, Senator Bagby.
I'll ask the delegate if there is, I've heard talk of potential compromise as it relates to some language. Is that still being discussed? Where you at with that?
Delegate.
Madam Chair, Senator Bagby, I would ask that we listen to the testimony. I know I want to continue this conversation. There is some language that's floating around that I think would move this, it gets this closer to where we need to go. And so I don't know that everyone is in agreement with that, but I think that the bill before you should hear the testimony and then the subcommittee decide, but I'd certainly be open to compromise if we can get there. I think everyone wants to make that happen.
Thank
and
you.
I think there's a way to do that.
Thank you, Delegate Hope. If you'd like to bring your witnesses forward, happy to hear from them. If you would introduce yourself and tell us who you're with. There's a chair right in front if you'd like to sit and speak.
Madam Chair, members of the committee, my name is Stuart Prost. I am with the National Federation of the Blind of Virginia. We are the largest organization of blind persons in the Commonwealth. We have 12 chapters, and we have members throughout Virginia. We are in support of House Bill 516. We believe that this is an issue that is going to make blind people more independent. It's going to make a way for people to take responsibility for taking their own medications. It is going to avoid potential harm, as the delegate has said. The most important factor in all of this is that we have to find a way that people can identify their prescriptions. In some of the things that we have seen in terms of reading, we want to make sure that any issue, any process is done in such a way that you can identify it on the bottle. That is very important. There was some talk of that substituting counseling for that. That's all well and good when you're at the pharmacist, and pharmacists are very good at doing that kind of work. And when I have a great deal of respect for pharmacists, but it's a lot different when you're sitting at home at your kitchen table in your medicine cabinet and you're trying to figure out which medication to take. So whatever comes out of this, we want to make sure that there is something on the bottle that is identifiable. Now, as far as how that works, and there are a number of pharmacies that already have the system. There's a system called Script Talk. And the way it works is that the pharmacist gets software for $200 a year. You can lease the software. You can have it standalone or integrated into your system. Then what it does is it creates, and then you also have to have paper, a special paper for it, which is like $1 or something per prescription. It is not an undue cost. Then the way it works is that the system creates a QR code. I have here a little demonstration here. This is a bottle that one of our members in the Tidewater area gave me to show you, and you can see that it has an RFD code on it. The way the code works is you take your iPhone and you scan it. I don't have it because I don't have the software, and also the person asked me not to, to keep that person's confidentiality. But it means that that person can take that medication and know exactly what it is, have the information, not only what is the medication, but what is the dosage, and all the information that is in the inserts that we all get. So we want to see a system where everybody has access to this. Why does every pharmacy need to participate? Is that some people can't get to only but one pharmacy, particularly in rural areas. Secondly, some people have insurance that have preferred providers, and we want to make sure that they can get to their preferred provider and get the maximum benefit from their insurance. We want to work away with the pharmacy community to make sure that it's not an undue burden. We don't want this to be difficult or expensive for pharmacists. We want to make it mutually agreeable, mutually workable, so that you as pharmacists can do your professional job, and we as the consumer can take our responsibility and take our medications independently. So we urge passage of the bill, and I thank you for your time. And we have another member who wants to speak to this.
Thank you very much for your time.
I'm sorry, was there a question?
Yes,
Go ahead, Marnie.
if you'd like to take a seat, that would be perfectly fine.
Hi.
Good morning. If
Good
you
mor-
introduce yourself and
Yes.
let's try to.
Yes.
I think we understand the concept of what the bill is.
So my name is Bernard Warwy. I live in Bon Air, Virginia, which is in North Chesterfield. I work full time. I work for the Department of Defense. I'm a contract specialist. Tomorrow I'm going to my CPA to pay my taxes. I itemize. My copay for my pharmacy is over $1,200. I take a lot of prescriptions. I do use one pharmacy called Accessible Pharmacy out of Philadelphia that uses Script Talk, but I only use them for two prescriptions, and that's for my glaucoma medicine. And so I have Script Talk on my phone. I could scan that barcode for you that Stuart has, but I don't want to violate that lady's privacy. The pharmacy that I use here in Richmond does not use Script Talk. I wish they did, because when I go to new doctor. I can't tell you the medications that I take off the top of my head, and I can't tell you the dosage, and I'm at a real severe disadvantage. So there you have it. I mean, I can buy military aircraft parts for the government, for the warfighter, but I can't tell you the medications that I'm on and the dosages that I'm on. And that's putting me at a severe risk for my medical future. So
Yeah.
I'm here to answer any questions and tell you that I'm in support of this bill, and I would appreciate your support. And thank you.
Thank you for your testimony. I think we do understand it. I see that we have a long line of people. Is there anyone else in support of the bill? If there are, okay. If there are people who are in opposition, I'm going to have to hand the gavel over to my colleague, Senator Pillion, because I've got to go out of here. But if you all would like to, if we want to pause and take testimony.
Proxy 3.
Okay, if, we might have to take a pause because we've got a lot of people who have to go.
Madam Chair, do you want to hear the testimony at least?
Yeah, you all can hear the, would you feel comfortable hearing the testimony while I run out for a few minutes? Okay, and then we'll have to pause. My apologies.
Okay.
All right, so we'll take opposition.
Mr. Chair, members of the committee, Chris West with Kaiser Permanente. We're not opposed to the intent of the legislation. We support the availability of accessible prescription information for our patients. We offer a variety of communication solutions for members who are blind, low vision, may have difficulties with remembering, understanding, and or hearing. However, we are concerned with the operational roadblocks in trying to comply with the specific language mandated in the bill. Pharmacies should have the flexibility to meet their patients' needs without overly prescriptive requirements such as mandating specific formats and technology as required in this bill. The Americans with Disabilities Act outlines and requires by federal law what pharmacies are required to provide for their patients. As stated in the ADA, in order to be effective, auxiliary aids and services must be provided in accessible formats, in a timely manner, and in such a way as to protect the privacy and independence of the individual with a disability. When the ADA was amended in 2020, it included more detail and clarified instructions on how public accommodations, specifically citing pharmacies, must provide auxiliary aids and services to blind or low vision customers in order to provide effective communication and medication adherence. The language specifically lists large print materials, Braille materials, and accessible electronic and information technology as recommended solutions. Additionally, in 2012, the federal government passed the Food and Drug Safety Administration Safety and Innovation Act. As part of this act, the U.S. Access Board was authorized to assemble a working group with representatives from pharmacies, the deaf, blind, and visually impaired advocacy communities. That working group developed a list of best practices and recommendations for pharmacies to implement and follow in providing access to prescription label information. They included detailed advisory criteria for producing large print, audible, and Braille prescription labels. They were clear that a one-size-fits-all package would not work. This would ensure that blind and visually impaired patients would have safe, private, independent, reliable, and consistent access to prescription label information. The updated language of the ADA now obligates the pharmacy to consult with the individual, find out what aid is needed to ensure effective communication of critical information. The FDA Safety and Innovation Act requires pharmacies to provide access to label information that meets the needs of the patient by outlining and detailing how to provide multiple solutions for the effective communication to blind customers. Let me be clear, we are absolutely committed to providing our visually impaired, blind, and print-disabled members with the tools that they need to take their medications properly and safety. However, we are concerned with the language that mandates the certain technology. Thank you.
Madam Chair, members of the subcommittee, I'm Hunter Jamerson for Epic Pharmacies. We do share the concerns that have been voiced. Excellent. And we have proposed a substitute to Delegate Hope, which I appreciate that he's considering. I think your council has copies. But I'll call your attention to the primary difference in the substitute from the introduced bill that we suggested to Delegate Hope, and that's to create a category C2 that would read as determined between the pharmacist and the patient, provide appropriate counseling and accommodation to the patient, and dispense the medication in suitable packaging with sufficient labeling and other information. And this information may be included on a recording or separate document attached to or included within the medication packaging. Because one of the concerns that we have is there are presently pharmacists and patients who have arranged accommodations customized to that patient and that pharmacy based on the technology available to that pharmacy, the technology affordable to that pharmacy, or to the preferences of that particular patient. We want to make sure as we move forward in solving what clearly is an issue that we don't disrupt what's also working presently for those who've reached accommodations on their own. So we appreciate Delegate Hope considering the substitute. I think it might give us an opportunity to keep refining this language. This is obviously an issue that has to be addressed to ensure access and safety. We want to make sure we do that in a way that balances the ability of the pharmacist to bear an additional mandate. Thank you.
Let me ask you.
Yes, sir.
Madam Chair, let me ask a question. So you said to ensure access and safety. Do your pharmacists not feel like that's currently being given through the ADA guidelines already?
I think that, Madam Chair, Senator Pillion, I think the ADA guidelines certainly do give us that flexibility. I think that the bill as introduced would impose technology requirements that aren't imposed on us by the ADA requirements. The introduced bill includes a braille printer. That's something that Delegate Hope has told us he's very willing to work with us on. Also includes large print font requirements, labeling requirements, audio labeling, readers. These cost money. And this is worth spending money on. But I think we need to make sure that we're doing this in a way that both balances that mandate on the pharmacy as well as recognizes there may be customized solutions. Some of my pharmacists have told me that they use different shaped tops to help distinguish the medications. They use multiple bottle packaging to help distinguish medications, as well as counseling the patient to the patient's satisfaction. Those are non-technological solutions that are currently in practice. We don't want to disrupt what's working. But at the same time, want to recognize technology continues to change. There continue to be advances, whether by board regulation or through codification. I think we can find the right words. I just don't think we're there yet. And I hope the subcommittee will consider the substitute as a signal to tell us all to keep working on this, maybe through conference, and get to the right place.
Thank you very much. I see that we have a lot of people who would like to speak. If we could keep it brief, I think that it has been communicated what the problems and the challenges are. So introduce yourself and let's
Thanks, Madam
try
Chair.
to keep it
Howard
tight.
Estes, representing the Virginia Pharmacy Association. I won't belabor some of the comments that have already been made already. I would say that we are worried about additional concerns with workflow and training of staff to use this specific hammer when there's so many other tools in the toolbox that we can use to meet our patients' needs. This was a surprise to us a little bit because we have the Board of Pharmacy and we've never heard any complaints regarding this issue. And really we think at the Board of Pharmacy that's a place where we can find ways to find best practices and also provide guidance to pharmacists of new and better technologies that don't even involve cell phones. So
Thank you very much. If you could just indicate a yes or a no, and I think that you're all.
Jody Roth on behalf of Virginia Association of Chain Drugstores. We do oppose this bill. One of the biggest concerns for my members is being pigeonholed into one specific technology.
Thank you.
Good morning. My name is Natalie Nguyen, and I'm the president of the Virginia Society of Health System Pharmacists. I would appreciate a little bit of time to share about our personal experiences as an actual practitioner, if that's all right. So we do support all accessibility options as part of the various strategies to improve health outcomes. After the previous discussion on the the House side, we have spent considerable amount of research to better understand the needs within this area. Per the Script Talk website, one of the vendors that offers such prescription accessibility tools, there are 303 pharmacies in 126 zip codes in the Commonwealth that currently covers 14.25% of the Commonwealth. And so there is a need to address this concern. We'd certainly like to acknowledge the previous comments with regards to cost and certain other barriers so we can continue to work through that given the current pharmacy deserts. I do want to share from the practice experience, the current language recognizes certain ways to help patients. When we interview patients, barriers identified to medication adherence can include limited health literacy, polypharmacy or taking many medications, socioeconomic barriers that prevent the patient from taking medication as directed, other disabilities such as hearing impairment. For instance, a visually impaired patient taking 13 medications may find that combining medications due at the same times in blister packaging may increase adherence because the patient is not having to open up every single prescription bottle. In addition, medication therapy management appointments with the pharmacist could even simplify the regimen by switching to long-acting agents or other options with a more optimal schedule. The way the language is written now certainly has opportunities to think about how we can permit customized approach for patient care. So we appreciate the opportunity to continue the discussion and work with all the stakeholders. We recognize the intent of this bill. We certainly don't want to limit that. Again, as pharmacists, we appreciate the opportunity and the patron for considering additional substitutes.
Thank you very much. I have another committee that is waiting for me to do another bill. I feel like we've had testimony. I can see that the three of you are still there. Is there a motion? Does anyone have a motion?
Parliamentary inquiry, I would say, would it be appropriate, because there's been some discussion about a potential substitute, but I don't think the patron's ready for that yet, but might we take no action at subcommittee on this bill and then just seek hear that in full committee and see if we can get a chance to sort it out?
I'm open to the substitute if we get to keep it moving.
Okay. I would be amenable to that as well. If you feel like you could get to a place that we would have some peace in the valley, if that would be acceptable.
Yeah.
So if we could entertain a motion of, or an understand, I mean, I guess if we're not going to do a recommendation, could you give us some guidance on how we would best move forward with that?
Madam Chair, you could take and explain to the community the situation.
Okay.
Madam Chair.
We could move it forward with no recommendation, I believe, and then. Okay.
Or we can also frame it now and then just to look at, because we don't necessarily.
Can you speak into the microphone so everybody in the room can hear?
Madam Chair, depending on the will of the patron, there's nothing precluding the subcommittee from right now if the patron wishes to offer the substitute, getting a chance to look at it. We could then offer it electronically, but you need not necessarily vote to recommend reporting with the substitute. You could just vote to recommend reporting, and then the potential substitute is out there sort of with the understanding that there could be further work on it between subcommittee and full committee next Thursday morning. Or additionally, as the idea was floated before, we could simply move to report and then offer the substitute for the first time in full, or move it forward with no action.
Thank you very much.
So, Madam Chair, whichever one that is now. Yeah. So, Madam Chair, if the custom that we do not accept public testimony and full, and this piece of legislation has a lot of testimony from both sides that will not be heard in the full committee, that I think probably needs to be heard. Is that something that you're willing to talk to the chair, and perhaps have full
Senator Pillion, I will
testimony?
speak to the chair and ask that, because this is a kind of an extenuating circumstance, and this is going to be a new concept, that perhaps she would have the grace to be able to give you a little bit more time to have the bill heard. Or
Madam Chair, could we move the substitute? And
we could move
at a minimum that keeps
I
the
didn't
train.
understand that we had a substitute ready for us.
So it wasn't totally established as to whether the patron is going to want to offer it. It wasn't officially, so at the time, I prepared this early this morning because it wasn't officially understood that the patron, whether the patron would be willing to or actually intending to offer it or not. So it was sort of an anticipatory, just in case preparation. But this is the substitute that some of the speakers had brought up and discussed, and this is the substitute to which the patron is referring.
And I think that the substitute takes a lot of the original bill, but it also allows for what's working to continue to work. And so I think it's closer to a consensus. I think where we'll end up, if there is one to be had. And so my preference would be to adopt a substitute to keep the thing going. And I'm happy to work with stakeholders in conference. If there's not going to, and Senator Peel, you might want to be on the conference. If there's not a consensus and an agreement, something's not going to come out of conference. But
And Madam Chair, I would, and Delegate Hope, I would assume that if you accept the substitute here, you'll accept it when it comes back to the House side.
no, I will reject it because I want to go to conference.
Okay. You want it in conference so we can.
I think we need more time.
Okay. Okay.
Okay. All right. So it sounds like if there are no other questions, there a motion to accept substitute first? Were there questions?
I would move the substitute, but I think what I would like to do is move the substitute with the understanding that we're not going to make the recommendation from the subcommittee at this time, but move the substitute, and then that would be the only thing that we would say, we adopted the substitute. but
Continue it to full.
Make no recommendation on the bill. So I would.
I think that's what you asked for, right?
Are you?
Well, what's the difference between a recommendation and no recommendation?
Testimony.
We testimony, yeah.
You want the testimony? That's why
Yeah.
my concern is.
Yeah,
just
and
that there may
Senator
not be.
Boysko is gonna have the opportunity to talk, so, okay, we still need the motion to move the right? Yeah, second. All those in favor? Okay, aye. And the vote will be in full.
Yeah, I think we can get
Yeah,
there.
it'll move forward with no recommendation. Okay,
Okay.
are we good? Are we done?
No, I have one
Thank you,
more.
subcommittee.
One more?
Thank you. I have one more.
go
Delegate Williams had a dentist appointment, imagine that, today, and asked me to present his bill.
Okay, go
So House Bill 1545 allows the Board of Medicine to grant provisional licensure to physician assistants applicants pending exam results, valid for 6 months or until full licensure is obtained. If an applicant fails the exam, the provisional license is revoked, but one can reapply for it after failing no more than one examination. The revision aims to streamline the licensure process for physician assistants. He told me there was no opposition to this piece of legislation, and he apologized for not being here. This is similar to some of the other pieces of legislation that we have that we've heard today about provisional licensure and getting those practitioners into the market prior to full licensure, just to help meet the demand.
Okay, is there anyone, doesn't look like anyone's here for public testimony? Okay,
Move to recommend reporting.
second, that motion's been moved and seconded. All those in favor of reporting, say aye. Aye.
You wanna
All
call
right.
roll? Okay.
Goes, and we're adjourned. Goodbye.